Hi, everybody. I am Dr. Shehla Shaikh, reaching out to all of you all from Mumbai, India. And at the onset, I would like to thank Sir Dr. Hasnain for making me a part of this very prestigious IDF DAR conference. Sir has not only been a mentor for me, he has been a guide, he has been a friend, and he's actually the person responsible for all the interest that we have been able to garner as far as Ramadan fasting is concerned. And it gives me great pleasure today to be talking about the applicability of the new guidelines in India, the Prep Up study. You know, friends, whenever we talk about Ramadan, we basically always think in terms of the risks associated with fasting. We are talking about hypoglycemia, hyperglycemia, decay, dehydration, and all of us together at all points of time trying to make fasting as safe as we can possibly do for our patients. In this endeavor, all over the last few years, we've had the initial risk stratification, which was done for individuals with diabetes during Ramadan. We had the very high risk. We had where we told our patients not to fast. We had the high risk and the moderate or low risk. One of the critics of this often was that it was maybe a little too watertight. Maybe it did not allow individualization, and hence some of our patients who could potentially fast were actually not fasting because we categorized them into the high risk or very high risk and made very dogmatic statements that no, you cannot fast, which had a lot of moral as well as spiritual responsibility. In order to be able to make the fasting experience a little more individualized, and in view of the fact that we had now newer medications, we were able to monitor our patients better, we were able to educate our patients better, the entire concept of the 2021 IDF DAR practical guidelines took shape. The principle basically was very simple. The pre-Ramadan assessment, which all of us are familiar with, is done. Each risk element then, which I will talk about in a few minutes, would be assessed sequentially. There would be a risk score, and this risk score actually will decide what kind of risk this patient had and what recommendations you would give to your patient. This is the risk stratification tool which was used in our clinic during the last Ramadan. And as you can see over here, you would realize that depending upon the different parameters, be it a diabetes type and duration, presence of hypoglycemia, characteristics of glycemic control, self-monitoring of blood glucose, complications of diabetes, pregnancy, frailty, physical labor, previous Ramadan experience, fasting hours, and diabetes treatment, a certain score was created. Now, this score, if it was between 0 to 3, was categorized as low risk. Between 3.5 to 6 was categorized as moderate risk. And as we all know, more than 6 was categorized as high risk. The issue that we faced was, what was the applicability of this score? How easy was it to do, or how difficult was it to do? Is it something that you and me in our clinics, and we all know the period before Ramadan, Rajab and Shaban, can be very busy as far as patients are concerned, because a number of patients do want to fast. And along with that load, we have now also started requesting our patients to sort of time the annual checkup before Ramadan. So you are seeing a very big load of patients. And would it be possible for you to actually apply these guidelines for your patients in such a busy time of clinical practice? Keeping this in mind, we thought that we want to really understand how we would apply this risk calculator for risk assessment as a team which is made up of clinicians, a team which is having a diabetes educator, a team which is having dietitians, and what kind of advice we could give our patients depending upon the score which is computed. And could we possibly understand fasting patterns better and maybe make more informed decisions regarding our patients? One very important point, as I said, was how practically I could apply this calculator in clinical practice, as to what part of this risk stratification could potentially be done by the paraclinical staff and what part really needed to be looked after by the clinician looking after the patient, was some of the questions in our mind when we decided to apply this IDF-DAR risk calculator in our clinic. 664 patients, mind you, with type 2 diabetes who came to the clinic sequentially were asked regarding their desire to fast. 23.3% patients said they were not going to fast due to a number of reasons, maybe the risk of hypoglycemia, a bad experience in previous Ramadan. They had a number of them said they had symptoms regarding severe hunger and they were unable to tolerate those symptoms. There were varied reasons, to be very honest, why patients decided not to fast right at the beginning. There were 509 patients who did consent that they would be fasting during Ramadan, and these patients were subjected to the risk assessment as per the IDF-DAR 2021 guidelines. Patients underwent a pre-Ramadan evaluation. It is very important that when patients undergo a pre-Ramadan evaluation, an entire family is educated regarding Ramadan management in a patient with diabetes, because a patient requires the support of an entire family. I would not only say family, an entire community when they fast during Ramadan, so that we can make it a seamless experience for our patients. Patients who were categorized as high-risk patients were definitely given more support, were definitely looked, their results were sort of analyzed much more closely. They were asked to monitor themselves much more closely. They were given helplines to reach out to, and these patients received a lot more care and a lot more attention than patients who were in the low risk category. As I've already said, patients were categorized to the low, moderate, or high risk depending upon their risk score. It was seen that 40% of patients had diabetes for more than 10 years, and 45% of our patients were on an SU-based regimen with an HbA1c less than 7.5%. We at this point of time know that in spite of patients being on an SU-based regimen, especially if our patients are on a glycoside regimen, as we all know, the Dire Ramadan study did show that these patients did not have an increased risk of hypoglycemia except when they did not partake suhoor or took suhoor much more earlier than the expected time period. But medications, as far as medications are concerned, with the second generation SUs, it can be easily be adjusted to reduce the risk of hypoglycemia. 45% of these patients who were on SU-based regimen, mind you, friends, also had an HbA1c of less than 7.5, which actually theoretically does put them at a higher risk of hypoglycemia. But these patients did want to fast, and they were not classically in the high-risk group. Now, when we analyzed the category stratification of our patients, what we did observe was that 34% of patients were in the low-risk category, 42% of patients were in the moderate risk category, and 24% of patients were in the high-risk category. This was the categorization of the patients in our clinic. What we were surprised about was that one of the very important limiting factors during stratification is SMBG. A whopping 83% of patients did not want to really monitor themselves very closely during Ramadan. 25% of patients did not have a glucometer also. They just did not have a glucometer. And in spite of education, they did not want to really monitor themselves or buy a glucometer before Ramadan. That is an area, I think, which is very important, and often that could potentially move your patient maybe from a low risk to a moderate risk, because patients who may sometimes be on medication, which potentially can cause hypoglycemia, but if they're just not willing to monitor, it does increase the risk of fasting. We now have newer medication with lesser risk of hypoglycemia. And what we observed, that patients could be re-stratified to a lower risk as a result of these newer medications, which do not have a significant risk of hypoglycemia, and they can fast safely during Ramadan. That brings up a very important point, that our patients need to be re-stratified during each Ramadan. Patients cannot continue the same prescription that they followed in the previous Ramadan, which, mind you, a number of my patients do when they feel that, oh, they are absolutely fine and they really don't need medical advice this Ramadan. And especially if they've had an absolutely issue-free Ramadan experience. One very important thing that this stratification helped us is, it helped us understand exactly what was the problem area, where we needed to focus. It helped us understand which was the category which was actually contributing most to the risk stratification. And it helped us really identify that and potentially help our patients understand that this is an area of concern for you and you need to be very careful as far as this area is concerned, so that we could end up giving better, more focused patient as well as caregiver education. Our patients were contacted telephonically post Ramadan to understand whether they fasted, what was the duration of fasting, and what were the reasons they did not fast if they didn't. And we tried to correlate the entire risk score with the experience of fasting. And what surprised us when we telephoned our patients post Ramadan, friends, you would be surprised. 85% of patients in the low risk category fasted, which I think is something which you and me would expect. That would really not surprise us. But 80% of patients in the moderate risk category and 76% of patients, mind you, in the high risk category. And that is surprising, that 76% of patients in the high risk category did fast without any significant complication. That really sets you thinking, it sets you thinking that we really need to individualize risk stratification. We cannot afford to paint the entire picture with a single color, because in doing so, maybe we are not doing justification to our patients who want to fast in the high risk category and who actually can fast with a little help from us. Does that require us to rethink? Does it require us to re-understand what we are doing? And does it need for us to move away from what we were actually stratifying as mild, moderate, and high risk into a very, very individualized way of categorizing our patients so that they can actually fast without having any complications for the holy month of Ramadan? These patients did not have any events of severe hypo or hyperglycemia where they had to actually break their fast. Maybe newer medicines, maybe better monitoring, maybe better pre-Ramadan education, maybe families which are educated. There could be so many compounding factors which could have contributed to this entire scenario. Patients also very comfortably switched back to the regimens post-Ramadan. And again, Eid, which conventionally we were associating with a lot of significant amount of hyperglycemia. We all know it is 3 days of feasting. We were quite surprised when we saw sugar records and we realized that our patients did not have the significant amount of hyperglycemia. So maybe the Ramadan education that we are giving our patients is actually now beginning to give us dividends. What is very interesting, friends, is also that when you educate your patients during Ramadan, it actually has benefits throughout the year. Because that 1 month of concerted education that you give your patients, actually, it is almost, sometimes I call it akin to the metabolic memory when I explain it to my students, that it could possibly be that memory which helps our patients actually have much better sugars throughout the year. So if I want to conclude on this, I would say that yes, patients in the moderate and high risk category do desire to fast in spite of the categorization. The categorization basic is a red flag that yes, these patients need more attention. Yes, we need to be more careful. Yes, we need to be sure that they can fast, and if they cannot, we tell them, no, you cannot fast. What is also very important, that it is possible to do all this in a busy clinical practice. It is possible for you and me, with a little help from a paramedical staff, who can potentially actually fill half the form before the form comes to you. And it is very easy for you to really understand what category of what kind of risk your patient has when the patient is sitting across you. As I said, high risk patients, we all know we've been all discouraging them from fasting, and we continue to discourage high risk patients from fasting if we think it is not safe. That goes without saying. But if your patients are still going to insist on fasting, then I think we also need to identify very, very categorically what kind of limiting factors we have and try to work on them so that we are able to help these patients make their fasting experience a much safer one. As I said, monitoring remains an area of concern. A lot of work needs to be still done. We have miles to go. But yes, we have been able to make this journey maybe a little more simpler, maybe a little more individualized, may be a little more easier for you, for me, and for the patient, because it helps us make a decision in a very, very individual way. It helps us make an informed decision regarding the risk of fasting, and potentially it also helps us make Ramadan a much safer experience for all of us concerned. Thank you very, very much for being with me. And I would again like to thank Sir for making me a part of this fantastic meeting. Thank you, sir.